This is written up three papers, session 2. So, session 3. So, just a brief introduction to all the presenters that they should start and conclude on time. The duration of each paper would be 6 minutes. Changing of presenting author is not allowed. And the membership number up to 26065 are ratified. So if you are we will be judging only ratified members. If there are any absentees, please indicate in the mark sheet clearly. Please do not consult your marks with other judges. This is for us. Okay, so let us start with the first presentation. And this is the presenting author, Antava. Yeah, yeah. So he would be presenting on evaluation of outcome of intravitreal bevacizumab with or without triamcinolone. I think TA is triamcinolone.
Yes.
Yeah, for wet AMD. Presentation.
Good morning, everyone. Today I am here to discuss on my topic, evaluation of outcomes of intrabutyral bevacizumab with or without triamcinolone acetonide for wet AMD. Age-related macular degeneration or AMD is one of the major causes of severe diminution of vision in people aged 50 years or above in both developed and developing countries. There are two main types of AMD, neovascular and dry. As we know that wet AMD consists only 10 to 20% of all AMD cases but accounts for 80 to 90% of AMD associated severe visual impairment. Neovascular AMD is caused by abnormal neoangiogenesis leading to choroidal neovascularization. Since new blood vessels are fragile, therefore fluid tends to leak in the macula, leading to photoreceptor damage. Thus, both inflammatory and angiogenic mechanisms are responsible for this, VEGF being the most important factor. Therefore, combination therapy can suppress both mechanisms, and we can expect better outcomes as compared to monotherapies. The aim of our study was to compare long-term outcomes of IVB with combined IVB and IVTA in neovascular macular degeneration. Our study was prospective study on 50 eyes with wet AMD visiting tertiary eye center from July 2020 to June 2022. Informed consent was taken from all patients and they were divided into two groups, 25 each in group A, that is IVB only group, and group B, IVB and IVTA group. Baseline evaluation like best corrected visual acuity, fundus evaluation, slit lamp evaluation, IOP assessment, if fundus fluorescent angiography, and OCT examination were done. Group A received 3 consecutive IVB injections on the first visit in month 1 and month 2. In Group B, triamcinolone acetonide was added to bevacizumab in first injection and rest were IVB only. Patients were examined after 24 hours of injection to see for any signs of ocular inflammation, and follow-ups were done at following months after injections, that is first month, second month, 4th month, 6th month, 8th month, 12th month, and 10th month and 12 months. BCVA, IOP and OCT were recorded in every visit. FFA was repeated at 3rd month and when considered necessary thereafter. All those patients with age 50 years and above with FFA diagnosed active CNV in one eye and with baseline visual acuity ranging from 6 by 18 to 3 by 60 without any prior ocular disease and with a minimum follow-up period of 12 months were included in the study. All those patients having any allergy to medications used in this study or any other ocular disease like glaucoma, diabetic retinopathy, or any arterial occlusion or any retinal vein or arterial occlusion or any macular pathology other than AMD were excluded from the study. Re-injection was considered in cases of visual of more than equal to 5 letters with OCT evidence of retinal fluid, increase in CMT with more than equal to 100 micrometer, or any new classical CNV or increased CNV area. The principles of declaration of Helsinki were followed and approval was taken from Institutional Ethics Committee. Out of 50 patients, 28 were males and rest were females. At 1 month follow-up visit, BCVA improved, but maximum improvement was seen at 6 months after first injection in both groups. However, compared with the baseline, average BCVA improved by 10 letters in IVB group and 15 letters in the combination therapy group after 12 months. Mean CMT decreased more in the combination therapy group, that is by 138 micrometer after 12 months. Better anatomical response of pseudophakic eyes was seen to the combination therapy, and it was evident from 8 months onwards. And average number of re-injections were also lesser in group B as compared to group A. Increase in IOP were seen in 2 patients, both from the combination therapy group at first week after first injection. However, they were treated with topical IOP lowering drugs, and subsequently the IOP decreased. No cases of cataract, endophthalmitis, retinal detachment, or any systemic adverse event were seen. Now these are the two graphs. First graph is showing the comparison of best corrected visual. So first graph is showing the best corrected visual acuity outcome in for comparing both the groups, and the second graph is showing the central macular thickness reduction in each of these, both group A and group B. As we can see that there was very significant improvement in best corrected visual acuity and also reduction in the CMT in the combination therapy group. Now, this is a fundus photograph of a 50 years old male with right eye wet AMD at first visit prior to combination therapy. FFA was done in the same visit in the same eye, and OCT finding was also noted. Now, after 12 months, we can see very effective and significant CMT reduction at 12 months follow-up visit after the combination therapy. Now, this is an OCT finding of a case with left eye wet AMD, 55 years old male, at first visit prior to only IVB therapy, that is group A. And then we can see that there was reduction in the CMT, but it was not as significant as compared to the combination therapy group. In long run, combination therapy is effective in improving the BCVA and decreasing the CMT in patients with wet AMD. Moderate dose was administered as adjunctive treatment only at the time of initial injection to avoid the complications of higher doses. Single injection can provide significant benefit at least up to 12 months, and similar results were seen by Colescirio and Jonas. So limitation of study were small sample size and longer follow-up period was also required. So to conclude with, we can say that due to greater visual gain achievement, lower retreatment rates, and sustainable improvement in CNV, intravitreal bevacizumab triamcinolone combination therapy could be a useful treatment option for wet AMD. Thank you. These are my references. Thank you.
So
How-
I have one question, that did you differentiate between AMD and IPCV, or were they excluded IPCV cases?
IPCV was excluded from the study. Any other macular pathology was excluded. Only CNV, classical CNV patients were only included in this study.
Audience has one question.
No. PDD treated patients were excluded. Any patient, all those patients which were selected, those who were selected, they were all treatment naive patients.
Naive patients.
Yes.
How do you
The
randomize?
triamcinolone was given only at the initial time, no?
Pardon, ma'am?
The Kenacort injection was given initially only. First dose, only one dose was given.
Yes, ma'am.
No, Redmond.
So, sir's question was how were the patients put into different groups? Whether randomization was done or it was just
Randomly, they were divided into.
how was the randomization done?
Randomization, we just those patients who came with any severe with any grade of severity of AMD, I selected them and just put them randomly in both the groups, group A or group B.
Okay, thank you.
That is the question. How do you decide which group, which patient to go? That is what called is randomization.
I actually, first of all, when they visited for the first time, I marked them on their papers that they were treated only with the bevacizumab, and the other patients I divided them under the combination therapy, and I separately marked them actually, and the division was just random.
The risk of glaucoma was ruled out. Matlab with disc changes. In that case, you decided to give Avastin only.
Yes, ma'am. First of all, I excluded if there are any signs of glaucoma are present or not. That is why baseline evaluation, like IOP assessment, fundus evaluation, everything was done to rule out any type of normotensive or any other ocular hypertension or any other primary open angle or angle closure glaucoma. And
How
then,
much was the rise in IOP you noticed in the group A?
the rise in IOP was not that much significant. Only 1 to 2 millimeter mercury was seen, but in the combination therapy group, there was little bit rise in that group, and it rose up to 25 or 30 of mercury, but it got controlled.
Thank you. Nice one.
You had said that the number of injections between the two groups,
Yes,
there was a slight difference. Was it statistically significant?
not that much, but little bit only significant. But it was not as significant as the purpose of our study.
And why was the combination chosen rather than switching on to a stronger anti-VEGF?
Because since I carried out this study in the peripheral areas, and since they are in those areas, patients are very poor and they cannot financially afford those costly anti-VEGF injections. And triamcinolone acetonide is available in little bit cost-effective prices, so that is why I try to carry out for their benefit.
Okay. Thank you.
Thank you.
There is Professor Dr. Pradeep Kumar, Brolucizumab in neovascular AMD, the Indian experience.
Morning to everyone. So this research is a little bit old now. It has been published earlier, about 6 months back. And so I'll start with the Indian experience of brolucizumab in treatment-naive neovascular AMD. Dr. Chakrabarty's work was published earlier than us, and it talked about the injection in all kind of neovascular AMD. But we were choosing neovascular AMD eyes which were treatment-naive here. And why we decided to compare brolucizumab in India, one, there were racial differences compared to the Hawk and Harrier study results. There was an environment impact. And also we wanted to find out whether the supply chains were authentic till the last modem. And we wanted to remove any commercial interest, us being a government organization where the cost of treatment does not make any impact on the patient or the doctor's choice. So this was our research which was published. And why we wanted to compare it with aflibercept was because aflibercept was conventionally well accepted molecule and was believed to have a stronger anti-VEGF effect compared to ranibizumab, which was the conventional molecule as of 2020. It was believed to be longer lasting. FDA approval was already available for 8 weeks. And we wanted again to find out, if we remove the price tag, which particular drug will be chosen by the doctor. So the unanswered questions were whether brolucizumab gave better visual recovery compared to the conventional molecules. Was it able to increase the inter-injection interval? What were the adverse events in Indian population? And if those adverse events occurred, were these eyes lost forever? So these were the necessary approvals which were taken. And we went ahead with the same inclusion and exclusion criteria as Hawk and Harrier. Pertinent to mention that patients with vision less than 3/60 were not considered for this particular study because the impact of anti-VEGF in changing the anatomical structure, whether it translates to visual differences, cannot be ascertained at less than 3/60 visual criteria. So we took the necessary approval, the consents, and the randomization was done based on simple randomization envelope calculator system. There were 3 initial loading doses, and after the 3 initial loading doses, the patients were examined at mandatory 4-weekly interval. This is where we deviated from the Hawk and Harrier module. We did not give a necessary 8-weekly or 12-weekly follow-up schedule. The follow-up schedule remained at 4-weekly intervals. And whenever these retreatment criteria were met, the patients were re-injected. The adverse events were graded as 1 and 2, which are common side effects which are seen after any intravitreal procedure. And grade 3 and 4 were the interesting side effects, where grade 3 required topical steroids to be administered, and grade 4 were the serious events where systemic steroids had to be given to manage the patient. We had well age and sex match control groups, 56 patients being in brolucizumab group and 58 being in aflibercept group. And the baseline visual acuity and the central macular thickness criteria were similar. We were also trying to find out that what were the changes occurring in different compartments of fluid at the macula, that is the IRF, SRF, and the subretinal component. So this is how the BCVA behaved, and as expected, both aflibercept and brolucizumab caused vision to improve significantly. In brolucizumab subgroup, it was just a shade better, but not statistically significant. But what was interesting was the change in the central macular thickness. As has been reported by other authors, the drying effect of brolucizumab is higher. It was 112 micron in this subgroup compared to 86 micron in aflibercept group. And we tried to find out that which was the fluid compartment which was being affected the most. It was the subretinal fluid compartment which was being impacted at 8, 12, 16, 36, 44, and 48 week, the maximal. We also found out that the inter-injection interval after the 8th week dose was much higher in the brolucizumab subgroup requiring only 94 injections up to 48 weeks in the total group compared to 180 aflibercept injections. And the duration was mainly between 12, 16, 20 and 24 week in the brolucizumab group, while in the aflibercept group we realized that patient behaved between 4 to 12 week interval at the most. Compared to the adverse effects, brolucizumab group did have significant adverse events, as in score 3 groups.
Screen.
There were 9 such score 3. Apologies. So let me continue. The score 3 events, which were requiring topical steroids, were about 9 such events in brolucizumab group compared to just 2 such events in aflibercept group. And the severe effects, where we had to give systemic steroids to patient, occurred only in 1 patient in our brolucizumab group, while in the aflibercept group, no such events occurred. So what we gathered out of all this was that brolucizumab was giving a longer inter-injection interval. It was working just as good as aflibercept as far as visual gains were concerned, and it did cause significant adverse events, but the adverse events were manageable. And if we talk that what are the impact it's going to make on the country as such, one, it is going to reduce the visits of the patient to our clinics, and these lower number of injections are going to translate to better economy when the final pricing points will be concerned. The risk benefit ratio when compared to lesser number of intravitreal procedure in brolucizumab group will finally translate to almost similar as compared to aflibercept group. Thank you so much.
So thank you. It's the same. You show that the advantage is that it has increased the time interval between the injections.
Yes, ma'am.
But also, having said that, you show that there is a higher risk of adverse events,
Yes, ma'am.
which apparently you don't get in aflibercept.
Yes, ma'am.
Now, is it really worth taking that? Because despite you not getting any vascular occlusions, there's a potential risk of that. And we do consider that, that can happen in any patient, though the percentage risk is very low. So, will you give more, weightage to the interval time being reduced between injections, or more weightage to the risk of adverse events?
Ma'am, I'll give more advantage to the inter-injection period increasing. And now, since we are wiser over the period of time, we just concluded our 1000th injection last month. There were just 2 important adverse events in 1000 injections, and all 2 were recoverable. One occurred in our own hospital matron, senior lady. She recovered, and now she is maintaining the same baseline vision where we started from. Similar event occurred in another gentleman. Now, if these adverse events are manageable, these patients who are visiting me now at 3 monthly interval, it is a much better scenario. Our OPDs are leaner, we have lesser post-op visits, and these patients are happier because they don't have to come in so often. So if I translate this to patients who are not treatment naive, we are talking about 2 to 3 brolucizumab in a year compared to about 4 to 5 aflibercept. Our experience with aflibercept is also for about 6 years now. We know it's a good drug, but it has 4 to 5 injections per year, almost that is what is required. So that's my summation.
Our next speaker is Dr. Harsh Ramidipti. She'll be talking retinal transplant, a boon for retina. Query. Please start.
Good morning to everyone. My today's topic is renal transplant a boon for retina? This is my abstract. Aim of my study is to study course of the retinal changes in post-transplant cases for a better quality of life. Chronic kidney disease is an emerging health problem which has a substantial mortality and morbidity burden. as there is a structural and embryological similarity between the renal and retinal vasculature. The current study is proposed to evaluate the effect of improvement of the renal function post-renal transplant on retinopathic changes. This is an observational and prospective study. It was conducted in 72 diagnosed CKD cases, of which 56 cases were divided into two groups. 28 cases were diagnosed cases which underwent renal transplant, and 28 cases who didn't undergo renal transplant, which were matched for Agents X criteria. Study was done for a duration of 1.5 years. Each patient was observed for 3 visits at an interval of 6 months each for 1.5 years. Proper ocular examination and documentation was done in all patients. My study had a male is to female ratio of 2:6, of which 60% had both diabetes and hypertension. 27% had only hypertension, and 14% only diabetic patients. It was observed in a group with the CKD patients who underwent renal transplant that on the first visit 50% had diabetic retinopathy, 37.5% had hypertensive retinopathy, and 18% had other retinal findings, which was almost consistent in the further 2 visits. And it was noted in the group which didn't undergo renal transplant. On the first visit, 46% had diabetic retinopathy, 39% had hypertensive retinopathy, and 19% had other retinal findings. These are the graphs showing a comparison of the incidence of retinopathic changes in all the 3 visits, which shows that in patients who didn't undergo renal transplant, we saw an increase in the incidence of diabetic retinopathy in further visits, and also it was observed that the severity of the disease increased, staging of the disease increased, while it was bit stable in cases who underwent renal transplant. These are the fundus photo documentation done. Diabetic nephropathy is a leading cause of end-stage renal disease in patients aged more than 40 years. Hemodialysis, peritoneal dialysis, and renal transplant are some main modalities of treatment of such patients. In a study done by Rupak Roy et al., it was concluded that renal transplant had stabilized the retinopathy status in the majority of patients, although a minor subset of the disease course was unpredictable in few cases. Our study showed a similar stability in diabetic retinopathic cases in post-renal transplant patients. Study done by Chow and et al. Showed a stable visual acuity in follow-up period. Our study showed a stable documentation of the fundus changes in post-renal transplant cases, which was mainly in diabetic retinopathic cases. Another study done by Ramsey et al. Showed an immediate early worsening of diabetic retinopathy in immediate early post-transplant period. But however, such thing was not noticed in our study. My study concluded that post-renal transplant showed a stability in the progression of retinopathy as compared to those who didn't undergo transplant. This stability was particularly noticed in cases of diabetic retinopathy than hypertensive retinopathy. Visual acuity was not taken into consideration as it was affected because of cataract and other retinal findings. Our study was more strongly associated with diabetic retinopathy. Proper intervention in patients without renal transplant can also help in controlling progression of the disease. So regular ocular checkups must be done in patients without renal transplant so that we can intervene early for a better visual outcome. My take-home message of the study was that when a patient visits a nephrologist, a proper awareness must be created that with each visit of nephrologist should be corresponded with an ophthalmologist visit so that he can undergo a proper ophthalmic examination and we can intervene early accordingly. These are my references. Thank you.
Thank you. Any questions from?
Dr. Deepika, genotype and phenotype features in Leber's congenital amaurosis. Patients from tertiary eye care.
Hi ma'am, this
Screen is not visible.
actually I have two presentations. This is one of them. Can I go with them? They displayed this.
Go by the sequence only.
Yeah, please change the PPT. Good morning everyone. I am Deepika. I'll be presenting on genotype phenotype features in Leber congenital amaurosis patients. So I do not have any financial disclosure and none conflicts. 5% of all inherited retinal dystrophies are due to LCA and 20% of the childhood blindness is due to LCA. We all know that typically a LCA patient presents with severe affection of vision, nystagmus and eye poking. What is interesting to note is the fundus. Sometimes it can vary from normal to widespread RP changes like RP. So this is where genotyping will help to identify the disease thoroughly. The fundus phenotype varies with the affected gene and genetic variant. With 2017 US FDA approval for the RP65 type 2 LCA gene therapy, it is very important for our patients to have genotyped before any therapy starts. So with this background, we try to evaluate the genotype phenotype features in LCA patients. The main objectives were to analyze the genetic mutations responsible for LCA, to assess the phenotype and genotype in those genes. We also tried to understand one of the challenges for the genotyping in India, that is developing countries, that is affordability for the genetic testing. This was a retrospective study of 6 years. We included only those cases who were genotypically proven by LCA and matching to the LCA clinical definition as per standard guidelines. We excluded all the cases where we found that the genotype is not matching with the clinical description which was supposed to be fitting for LCA. The method of genetic analysis was always, the genetic testing was followed by after the genetic counseling. A blood sample was collected, a genomic DNA was isolated. It was for a commercial certified genetic laboratory. Patient's exome was sequenced using NGS technology. We did a panel of tests for all the IRD genes of 195 or more. It was the genetic variants which were found in the result were confirmed by Sanger validation. These are the results. We had 35 patients. Median age at presentation was 24 months, and all the patients had symptoms at less than 1 year of age, which is matching to LCA. The major symptoms were nystagmus, poor eye contact, and eye poking. Positive family history was noted in 28%. As this is retrospective, maybe some records will be missing. History of consanguineous marriage was noted in good percentage of amount, that is 54%. The mean BCV at presentation was very low, which if we convert into a regular OPD basis, it was just hand motion appreciation to perception of light. 8 patients at presentation were unable to even fixate on the light, and this was the complaint brought by the parents. In the fundus, RP abnormalities was the major change which was seen. As we noticed, I have put 4 images. So the fundus varied from being normal to subtle RP granularities, mottling, to a frank pigmentary changes and macular atrophy with pigmentation. So the optic disc is very important because in a typical case of RP, it might be having a pallor, whereas in LCA, we found that at presentation, 50 eyes had normal optic disc. Macular involvement was noted in 17%. 14 eyes had a completely normal looking fundus at presentation. So this is the gene and the percentage of their mutations. The major 4 genes which were responsible to cause LCA in our cohort was GUCY2D, the most common one. It was followed by CRB1, followed by RPGR-IP1, and then RP65, which was the approved gene therapy one. This is in brief. The table is a little bit crowded, but I'll just, I want you to focus on 4 things which I have highlighted here. In GUCY2D gene, all the pattern of inheritance was autosomal recessive. Most common type of mutational change observed was missense variant. Just focus on the age and visual acuity column which is there. All the patients had severe affection of the vision, ranging from just fixing or following of light and to just hand movement. 2 patients of here had normal looking fundus. The next most common was CRB1. There was little heterogeneity when compared to GUCY22, the previous table which I showed. They had this mixed pattern of inheritance autosomal recessive, somewhere compound heterozygous, and we also noted heterozygous autosomal dominant. Here we had 2 patients who had normal looking fundus, but in spite of normal looking fundus, the vision was very low, and one child in the last column, last row, was not able to fix the light. So what I would like to infer is that despite a normal looking fundus and vision will not be able to correlate anything in LCA, it is very important to perform certain tests like ERG or genetic tests to identify them. So this is a fundus of CRB1. Important thing in CRB1 noted was they all had macular involvement with pigmentation. This is RPGR IP1. One patient had Coates disease, which was treated with focal laser and intravitreal Avastin. RP65, all the patients had pigment mottling. Briefly, I'll just end up on this slide, which is very important for our scenario. The cost of testing lowered from 25,000 to 13,000 over the period of 6 years. The median amount spent for genetic testing noted was 18,000. These are all the tests where the patient had gone or the parents have gone to the genetic testing, and it was paid by them only. So it is very important because the patient is paying the amount, and more number of testing requested led to cost reduction. That's what our assumption. Still, majority of our patients will not be able to afford this amount. It warrants active involvement or collaboration with clinicians and genetic certified laboratory to work on either narrowing the panel of genes so that the cost will be reduced, or direct cost reduction by discussion into the company. So to conclude, these were the 4 genes which are common in our LCA cohort of India, and they are very heterogeneous with severe affection of vision. Thank you.
Any questions?
Thank you.
Hello everyone. So my paper is on novel genotype, phenotype and possible gene therapy in Stargardt's disease. As we all know, this is the most common inherited juvenile macular dystrophy caused by ABCA4 mutation, and 95% of Stargardt's happens because of the ABCA4 mutation. ABCA4 is basically located in chromosome number 1. It codes for transfer protein, which involves removal of all trans-retinoidehyde to regenerate rhodopsin. So whenever there is a defect mutation ABCA4, there will be inefficient degradation, excess accumulation within the cells, leading to apoptosis and Stargardt disease manifestation. This is what happens. So purpose of our study to report all the novel genotype, phenotype and possible therapy in Indian patients. So this was an observational study with all necessary approvals were taken. This was the roadmap of our study. First was to identify the families with Stargardt disease, identify and isolate the mutation, study this mutation in cell lines, then how to repair this mutation, and then to study the effect of this repair. So our cohort had 39 families with 50 affected and 94 unaffected family members. For genetic testing, we used whole exome sequencing to isolate the mutations. So all patients underwent comprehensive evaluation, including imaging, and ERG tests were done wherever it was necessary with strict adherence to ISCV protocols. We had 29 males and 21 females in our cohort, age range between 9 to 64. The consanguinity was present in 28 families, that's almost 73%. So a spectrum of fundus abnormalities were observed from the classic presentation like this, where I have put an autofluorescence which shows central atrophic change with the flex. So this patient had homozygous mutation in ABCA4. This was one more 30-year-old female with the same mutation, but the phenotype was different. There were no flex, just a ring of hyperautofluorescence was seen. This was one more 46-year-old patient with the same mutation, but there was extensive degenerative changes involving outer retina and also choroidal changes with cavitations and skytic changes, which has never been reported in the literature. This was one more interesting family where the proband was 14-year female and mother was asymptomatic and she was 35-year-old. The proband, the daughter had atrophic foveal changes, maybe an early Stargardt's. But when we did the genetic testing, she had a compound heterozygous mutation. Usually what we get is homozygous mutation. She had mutations at 2 different locations. And mother was positive for one of these mutations, but she was asymptomatic. But when we did an autofluorescence, she did had some abnormality in the fovea. So if you look at this, this is maybe a mild genotype. That's why its mother is asymptomatic. When there is a combination, the daughter is manifesting in a severe form. So this is a typical example for same family, same gene, but depending on the inheritance pattern and the type of mutation, the clinical profile could be different. This was one more 43-year-old female. She did not fit into the classical Stargardt, just the appearance of it, but we still included in the study in the study because the father had a phenotype which resembled Stargardt's disease. When we did genetic testing, we discovered totally a new gene which has never been reported, which was pathogenic, but we are not sure which is responsible for this phenotype. You are waiting for others to report similar kind of mutations in Indian families. So, but incidentally, grandchildren also had a similar mutation. When we asked them, they were asymptomatic. When we saw the fundus was normal, OCT was also normal, but autofluorescence did had changes in the grandchildren's. This is the OCT and fundus autofluorescence across 3 generations with increasing severity. Most of the mutations in our cohort was missense mutation. Missense basically means there is a single base pair substitution leading to new amino acid synthesis, and 8 of them are novel. So how all these novel ones are pathogenic? For this, we did a cell line study using HEK cell line where ABCA mutation protein expression was studied in Western blot analysis. To make it simple, the darker and better the band, better the protein production. These are all the different 8 mutations of ABCA4. If you see the clinical example, this was a 13-year-old male patient with good vision who had a V type of mutation, but a very mild disease. If you look at the younger patient, that is 9-year-old with Q type of mutation with severe protein defect, had a severe disease. Even the ERG showed normal in the first patient, whereas second patient, though young, had a severe rod cone dysfunction. How to repair this? We came up with a novel concept because ABCA4 is a large gene which can't be loaded into the single vector. We split the gene into 2 off, loaded into separate variants, co-infected together, and they made to reach the target cells. So these are the harvested eyeballs from the mouse retina. If you see, as compared to the control, and also the intact vector, dual vector uptake is very good. We use beta-galactosidase staining to trace these vectors, so thereby ensuring that our vectors are reaching the target. So to summarize, what was known was this is how Stargardt's looks like and is most commonly caused by the ABCA4 homozygous mutation. What our study adds is we demonstrated genetic sequencing and screening of Stargardt's in Indian families and presence of new genetic and phenotypic variation which can happen in Indian scenario. And we also made an experimental model to study the mutation pathogenicity, the severity depending on the protein production. And also animal models were developed to study the dual vector efficacy. So all this were done in Indian settings. The vectors, everything was produced in India. So the ongoing project is we already produced a mouse model which mimics the human disease, and we have injected dual vectors in them. So if you see compared to the wild type, the autofluorescence expression is very good in mouse which received the injection of dual vectors. The same thing can be seen in the ERG also. As compared to the control vector and non-injected vector, the mouse which received, these are live the intact animals where the mouse which received dual vector had a better amplitudes. So our future plan is to study the epigenetic factor, which was a limitation for this study, and also to start the human gene trial. Thank you so much.
Any questions?
Sequential bilateral vitreoretinal surgery in advanced stages of retinopathy of prematurity. Slide is not moving. I have no financial interest. So ROP is a blinding disease in low birth weight preterm babies, and many of them present in late stages of ROP. So these babies need urgent intervention to prevent further damage and irreversible blindness. And these are sick babies which needs repeated general anesthesia, which is risky, and many a times they are not fit for the second eye surgery. And immediate sequential bilateral vitreoretinal surgery reduces the general anesthesia time compared to 2 single surgeries and timely management of the second eye. So there are different studies comparing the immediate sequential bilateral cataract surgery as well as other vitreoretinal surgeries, and they have found it as a useful modality, and that can prevent blindness in many of the cataract patients. So rationale of the studies: performing consecutive surgeries in bilateral advancing stages of ROP leads to a delayed surgery of the second eye with poorer outcome, and these sick preterm babies are unfit for the second eye surgery, and 2 GA sessions is a risky procedure, and there is limited literature regarding the outcomes of immediate sequential bilateral vitreoretinal surgery in advanced stages of ROP. So there is a need for comprehensive study to assess the outcomes in advanced stages of ROP. So, the aim of the study is to evaluate the outcomes of immediate sequential bilateral vitreoretinal surgery in progressive stages of ROP in stage 4A, 4B, as well as early stage 5 ROP. So, this was a prospective interventional study done at RP Center of 1 year duration. At least 30 eyes of 15 preterm babies of stage 4A, 4B, and early stage 5 were taken. And all babies underwent small gauge PPV plus or minus pars plana lensectomy in single GA setting after informed consent and pre-anesthetic clearance as well as pediatric clearance. Ethical clearance was obtained from the AIMS Ethics Committee. So inclusion criteria was progressive stage 4A, 4B, stage 5 ROP, gestational age less than 34 weeks, birth weight less than 2 weeks, babies have received anti-VEGF or laser, systemically fit for GS, general anesthesia, and parents willing to give consent for bilateral surgery. Exclusion was post-conceptional age more than 45, bilateral end stage 5 ROP, and any ocular comorbidity limiting the visibility for pars plana vitrectomy. So, after assessing the eligibility, 30 babies were enrolled, out of which 25 were meeting the criteria, and 1 was lost to follow-up. And finally, we have analyzed 24 babies of 48 eyes. So they were comparative in sex distribution. Most of them were single pregnancy, and mode of delivery was mostly spontaneous. And mean gestational age was 29 weeks, and birth weight mean was 1,300 grams. And post-consumptional age mean was 37.5 weeks. And the most common neonatal risk factors were oxygen supplementation, RDS, apnea of prematurity, blood transfusion, and jaundice. And reasons for advanced stage of ROP were late screening, late treatment, and no treatment, and late referrals. And there were no cases of no screening at our Apex Center. And pre-surgery treatment, 54% had LIO treatment prior, and 41% didn't have any treatment, and few cases had LIO plus anti-VEGF prior to the surgery. Most cases had Zone 1 and Zone 2 ROP. Stages were 4A in most of the cases, and few in early stage 5. Preoperative ocular parameters, early 8% had poorly dilating pupil, and most of them had more than 7 clock hours of TRD. And we have used only 25 gauge vitrectomy in all cases. And safety parameters, all surgeons and assistants were rescrubbed in between each eye, as well as separate OT instruments as well as fluids were used in each eye. Intraoperative surgical parameters, vertical traction was released in 24%, laser augmentation was done in most of the cases, air tamponade was done in all cases, and sutureless closure was done in all cases. Intraoperatively, we had retinal breaks in 8% of cases, and most common anesthesia challenge was difficult IV, difficult intubation. And post-op anesthesia challenge was prolonged recovery from anesthesia, post-op apnea, and desaturation. So total surgical time, the mean time was 82 minutes, and total anesthesia time was 154 minutes. So time schedule, we have separated it into each compartment. Mean preparation time for the I1 as well as I2, mean eye surgical time, mean rescrub time, which was 15 minutes in between the surgery, and mean surgical time for the second eye was 36, and mean extubation time was 22 minutes. So comparison, we had 154 minutes of total anesthesia time, and mean surgical time was 82 minutes, and total G exposure in one eye was 117 minutes, I2 was 93 minutes, and both eyes separately it was 210. If you had done the surgeries in a single sitting, it would be 154. The p-value is highly significant. And resurgery was done in 4% of the cases, and final outcome almost 80% had regressed, and 14% was partially regressed, and 6% had progressed. So these are the cases of stage 4A and 4B cases which has been regressed. And so to conclude, immediate sequential bilateral vitreoretinal surgery allows timely surgical intervention in both eyes in advanced stages of ROP, reduces the GA surgical time, as well as proper safety precautions has to be taken to prevent infection. So I recommend immediate sequential bilateral vitreoretinal surgery is a feasible option to manage bilateral progressive advanced stages of ROP. Thank you.
So I have a question for you, that why the bilateral surgeries are not wrong. You really don't want it to happen in both the eyes.
Yes, ma'am.
So what is the rate of infection at your center?
0%
At your center.
At our center, in my case series, we didn't have any infection.
Now, what is the generalized rate of endophthalmitis in your center?
It varies depending upon the type of surgery also. It is less than 0.01% probably, or even less.
see, we are dealing with premature babies,
Yes, ma'am.
and if we are avoiding the induction of the GA twice,
Yes.
but we are surely prolonging the duration of surgery in one sitting itself.
Yes.
So it's like it's a risk benefit ratio, and God forbid if any infection happens, then you are jacked up with both the eyes.
There are many case series of bilateral even cataract surgeries being done in the West, not in our setup, but they have fairly good outcomes with less endophthalmitis rate.
Cataract surgery
And
would be
I
a-
don't
cataract
recommend
surgery
it
would
for
be
a
different.
cataract surgery, but for a case which like an ROP or a glaucoma which needs immediate intervention to prevent a loss of vision. In such cases we can do. And our case series was advanced stages of ROP, not early stages. So
Especially when you are dealing with advanced cases of ROP,
yes, ma'am.
I see no emergency that if you are going to
Yes.
be operating the other eye in a 2 weeks gap, I don't think that it is going to really have a harmful effect on the other eye.
The thing is, most of the childs are underweight, and these are not fit for anesthesia in the second setting. Even we struggle to get a clearance from the anesthetist, and they say they have URI, they have some issues. So if you can deal in the first sitting itself, then it's better.
Prolonging the anesthesia time will also risk the
No,
premature
ma'am.
baby.
If you consider two separate sittings, the total anesthesia time was more. It was around 200 and 200 minutes. And if it was done in a single setting, it was 154 minutes. So we have totally reduced the anesthesia time in a single sitting. So two separate induction, two separate extubation. So you are prolonging the total anesthesia, two exposures.
Do you faced any intraoperative anesthetic risk, like you have to abandon the surgery because of some
we
anesthetic
didn't have to
problem?
abandon the surgery. We had two cases which we had to shift the child to ICU care. In the NICU, we had to shift. Other cases were shifted to the ward only, not to any ICU care.
What are the average weight of the child? What is the average weight of in the series? When you-
1,500 around. Average
weight of the child.
weight was 1,500 gram, most of the child.
Very nice presentation. You said that the average GA time would be more if you add up the two.
Yes, sir.
But you are doing two separate surgeries. So the GA total duration for one surgery would be still less than...
No, sir. Actually, the GA time to induce it takes time. If you have to maintain the anesthesia, they don't have to give additional drugs, additional induction agents. So you're just maintaining the anesthesia in a plane. So it is not increasing the risk of anesthesia. Even the anesthetist prefer to do in a single setting.
Thank you.
Thank you, sir.
Next.
My troubles. A new technique of scleral fixation of IOL, retrospective case series by Dr. Deepak
Agarwal, presenting my free paper on Fixing My Trouble, a new technique of scleral fixation of IOLs, a retrospective case series. So, scleral fixation of IOLs has advantages for correction of aphakia, like the IOL is placed at a more physiological position and it avoids complication associated with ACILs. A new surgical technique has been recently published by Dr. Boral et al. Any new surgical technique needs to prove its reproducibility and safety. The purpose of the current paper is to evaluate the efficacy and safety of Boral's technique for SFLs. In this retrospective case series, included cases where aphakia with posterior capsule, absent posterior capsule, and any case with less than 6 months where follow-up were excluded. Detailed history and ophthalmic evaluation was performed at all the visits. Post-operative anterior segment OCT was done for SFL stability at 1 month and 6 months. So surgical technique in the graphical representation I'm showing. First, a pars plana vitrectomy was performed, followed by a curved paralimbal scleral flap. Sclerotomies were made by a 25 gauge trocar, and only multi-piece foldable IOL was used. The IOL haptics was externalized by a 25 gauge serrated forceps, and these haptics were placed inside a scleral tunnel which was made parallel to the limbus. Paired sample t-test was used to evaluate preoperative and postoperative uncorrected visual acuity and best corrected visual acuity at 1 month. P-value less than 0.05 was considered significant. 33 eyes of 32 patients were included. The most common indication for surgery was aphakia after cataract surgery, followed by dropped nucleus and various other indications. When we see at the results, the preoperative, there was a significant improvement in visual acuity in both uncorrected and best corrected visual acuity. This is the graphical representation of the visual acuities before and after the surgery. Now, this is a very important slide where we are doing anterior segment OCTs through the optic as well as through the haptics. The figure 2A shows intraocular stable anterior surface and the posterior surface of the optic, and the figure 2B and 2C shows intrascleral haptics which are stable. Now, we didn't observe any intraoperative complications. During the entire follow-up period, vitreous hemorrhage was seen in only single case, which resolved without any surgical intervention. None of the cases showed retinal detachment or endophthalmitis, hypotony, or IL subluxation. Now, our study shows statistical significant improvement in vision, which was similarly reported by previous authors. So, how is this technique different from the previous authors? We made small sclerotomies by 25 gauge stroker. Vilguki et al. Used 20 gauge blades for making such sclerotomies. We believe small sclerotomies are advantageous because they decreases the chances of vitreous hemorrhage and hypotony. Vitreous hemorrhage and hypotony was seen in 8% and 4% by Vilguki et al. Now, how is it different from the Yamanese technique? The Yamanese technique uses an 27 gauge needle to externalize the haptics. We believe that threading of the haptics of the IOL into these 27 gauge needles intraocularly is a little difficult, and it's more challenging for a young surgeon. However, when we use a 25 gauge forceps, it affords a firm grip and is easier to manipulate inside the eye. Haptic dislocations were seen by 2.47% cases in Boral et al. And 13% by Vilguki et al. Present study reports no such cases of IOL or haptic dislocation. So the limitations of the current study are its small sample size, shorter duration of follow-up, and retrospective design. However, the strength is, it is the first study on sutureless glueless SFL from North Bengal. To conclude, Boral's technique of SFL is easily reproducible, effective, and safe. However, longer studies involving large number of patients will help in further understanding the safety profile. These are my references. Thank you very much.
These cases?
Minimum follow-up was 6 months, but it extended up to the 18 months as well.
Okay.
The largest follow-up was for the 18 months.
No late post-operative complication was noted.
No, only, and it resolved spontaneously.
Okay.
So I assume that the haptic is a PMMA.
Yes, madam. So it was a to be very frank, it was a Alcon multi-piece lens.
So did you have any breakage of the haptic while exteriorizing them?
No, madam. No. At times it is the haptics are larger. We might have to cut it with scissor for better insertion into the scleral tunnels, but there was no breakage.
Thank you.
Thank you.
So the next speaker is presenting author is Dr. Meghna. The outcomes of IL peeling in PDR undergoing vitrectomy for vitreous hemorrhage.
We studied the outcomes of ILMP in PDR patients undergoing vitrectomy for vitreous hemorrhage. I have no financial disclosures. As we all know, PDR patients undergoing vitrectomy for vitreous hemorrhage will have some underlying macular or vitromacular interface abnormalities. On the other hand, even after the surgery, the patients will have DME or ERM chances and macular ischemia, which further needs treatment for the same. And hence, we analyze the outcomes of ILMP in addition to vitrectomy in patients presenting with VH alone with no macular pathology to study the effects on visual acuity, development of ERM and DME, and requiring further retreatments. So ILM consists of internal expansions of the Muller cells. ILMP not only relieves the tangential traction, but it also reduces the addition of VEGF and other vasoactive and inflammatory factors. So primary aim of the study is comparison of WIT ILMP versus WIT alone in PDR patients with vitreous hemorrhage in terms of best corrected visual acuity and central macular thickness when preoperative macular status assessment was not possible. Secondary objective is to look for presence of DME and ERM formation after surgery. The tertiary objective is requirement of post-op anti-VEGF injections, resurgeries, and requirement of tamponade. So this is a prospective randomized interventional study. So patients presented with PDR with VH with no TRD on B-scan, only VH patients with pre-op macular assessment was not possible. We divided patients into two groups, WIT ILMP group as group 1 and group 2 includes vitrectomy alone. Intraop OCT was performed in all the cases to rule out any macular pathology. If presence of any macular pathology like DME, macular hole were excluded from the study. The outcomes were analyzed in terms of best corrected visual acuity, central macular thickness, occurrence of DME, ERM, requirement of resurgeries with tamponade, and requirement of anti-VEGFs. All patients were followed for one week, 1 month, 3rd month, and 6-month follow-up. So 70 eyes of 64 patients were included in the group. Each group had 35 eyes. The mean age of presentation was 54.6 in WIT ILMP group and 54.97 in vitrectomy group alone. So this is how we perform an ILMP being done using intraoperative OCT. So the post-operative and follow-up OCT of a patient from WIT ILMP group, wherein we can see at 1 month, 3rd month, and 6-month follow-up, the foveal contour is maintained and no ERM and no diabetic macular edema. So this is a post-operative and follow-up OCT of a patient from WIT group, wherein at 1st month itself, we can see there is appearance of ERM, and at 3rd month, the ERM is noted. Along with that, there is presence of diabetic macular edema in the form of cystoid spaces, and at 6th month follow-up, after injection, there is reduction of cystoid spaces, and there is persistent significant epiretinal membrane was seen. So the best corrected visual acuity was compared at different follow-ups. So we can see here in vitrectomized eye group, there is a marginally reduction in the visual acuity at 1st follow-up, but both the WIT ILMP and vitrectomized group have an improvement in the visual acuity. But compared to WIT ILMP and WIT group, at 3rd month had a statistical significant correlation in the visual acuity. In comparison with the central macular thickness, so in WIT plus ILMP group, there is a reduction in the central macular thickness, whereas in only vitrectomized eye group, there is a marginally increase in the central macular thickness than compared to the baseline. At 3rd month and 6th month, there was a highly significant statistical relationship significant. So next is occurrence of DME. As we can see here, there is more occurrence of DME at 6 months in vitrectomized eye than compared to the WIT ILMP eyes, which constitute about 6 eyes in case of WIT eyes, and WIT ILMP constitute about 3 eyes. Occurrence of ERM was more in cases of vitrectomy group than compared to WIT ILMP group. At 6th month, we account for about 11 eyes contributing for the ERM formation. So requirement of anti-VEGFs has been increased gradually in both the groups, whereas we can see the number of injections required for the vitrectomy group was more than compared to the ILMP groups. And also the requirement of resurgeries was more with the vitrectomy group, that is accounts for about 2 eyes, whereas none of the patients with WIT ILMP group required resurgeries at 6th month of follow-up. Requirement of tamponade. So in vitrectomy group without ILMP, they required tamponade in about 4 eyes, whereas only 2 eyes required tamponade in WIT ILMP group. So Mikulski et al., he studied the influence of ILMP in PDR with TRD status, wherein he he has taken into account irrespective of macular status, and he said that there is reduction in the CMT, there is less chances of ERM, more chances of ERM in case of vitrectomy group than in ILMP group was noted. Sketchet et al. Has said that there is recurrence of ERM more in the VIT group. Hartley et al. Used the study in the diffuse macular edema. Rashe et al. Used only in refractory diabetic macular edema. So IOCT, there is paucity of literature. CMT reduced progressively in VIT ILMP group. CMT increased marginally in VIT group. Occurrence of DME was less in case of VIT ILMP group. So ILMP is in primary surgery with vitrectomy gives better results in terms of reduced ERM formation, macular thickness, and number of resurgeries. Except for occurrence of DME, requirement of anti-VEGF and need of tamponade, statistically significant was seen in all the other parameters in VIT ILMP group. Thank you.
Nice presentation, Dr. Megha. I have just a couple of questions.
Yes.
One is that I guess the pre-operative OCT was not possible in
Yes,
majority.
sir.
So
Yes,
how
sir.
did you rule out pre-operative ERM in either group?
So we pre-operative ERM.
Yeah, the ERM can be there in the eyes
No.
before also,
Yes,
right?
we have done intraoperative OCT. None of the eyes had got done pre-operative OCT.
So, and the second question was the other parameters match between the two groups, like pre-existing lasers, other things.
Yes, sir. We have a chart prepared of like 4 eyes had previous history of cataract surgery and around 8 eyes had previous history of PRP, sir. But that relation to the DME and all was not.
Thank you.
All your patients were metabolically stable.
Yes, ma'am. Yes, ma'am. We have checked the HbA1c levels, which was around 6.7 to 7.5.
And in
Other, sir, excuse me? Sir, other one. We presenting a small in vitro experiment on retinal pigment epithelial cell viability with 41 gauge and 29 gauge cannula. So I do not have financial disclosures. Retinal RPE cells are a monolayer of cells in the retina, very important structure to maintain homeostasis of the retina. On the one hand, the diseases which are affected when RPE is not functioning properly involves the younger age group of retinal dystrophies. On the other hand, it is dry age-related macular degeneration. In both of them, the therapy can be injection of the RPE cells. So there are various cell types which are used for therapeutic RP cells, human embryonic stem cells, induced pluripotent stem cell, which are called as iPSCs. The safety of the RP product has also been demonstrated by various studies. The topic over here is the technique of delivery. Among the in the technique of delivery, the needle which is used for the technique for the delivery of the cells, that is subretinal delivery of the RP cells. So I'll be focusing on the gauge of the needle which is used for the subretinal technique. So with this, to evaluate and understand the optimal bore dimension for injection needles or polytip cannulas for their suitability in RP cell injection for a safe injection of the cells. It's a laboratory experimental study where adult RP19 cell suspensions were studied. 2 different bores of cannula with inner bore sizes of 41 gauge and 29 gauge were studied. To give a brief on why it is important, the average outer diameter of RP cell is 20 to 30 microns. For a safe injection of the cells, at least 2 to 3 times the diameter of RP cell is required, that is 60 to 90 microns. So the 29 gauge inner bore size corresponds to about 287 microns. The 41 gauge inner bore size corresponds to about 71 microns. So that's why these 2 needles, 2 different gauges were studied, one narrower and one wider. 2 different cannulas of 2 different concentration. The different concentration is important because there's a thought that the clinician wants to inject a higher concentration of cells for better efficacy. But at the same time, when we inject more cells, there can be shear stress of the cells causing damage of the cells through the passage of the needle. So that's why 2 concentrations were used. This is how the cells look in adherent culture before trypsinization and after trypsinization. Trypsinization is a method where the adherent cells will become free and they are ready for injection. This is how a live and dead cell look. So the live cells will be more translucent and the dead cells will take up the dye, that is trypan blue, and look blue. In summary, how the process was. After the cells were separated by trypsinization, their assessment of cell viability and cell death index was noted just before injection. And then after that, a 0.1 ml injection of cells were injected through 41 and 29 gauge bore size needle attached to a 1 ml syringe. Post injection at 0 hour and 6 hours, cell viability and cell death index was assessed. In the results, if we concentrate, this is the cell viability index. That means how many cells survived. So in both the concentration, in both the gauges of needle, more than 90% of the cells survived at both 0 hours and 6 hours of injection. What is important is to note that in the lower concentration, in the narrower gauge needle, at the lower concentration, there was more, the cell survival was less. This is indicated even with the cell death index, where we can see that in the lower concentration, that is 2 million, if we see, the cell death index is looking more in a narrower gauge needle when compared to the other end. So, whereas when we look at the end at 6 hours, both the higher concentration and lower concentration cells survived. These are indicated by the yellow arrow. These are the live cells. In summary, over 91 to 98% of the injected cells continued to remain viable at 6 hours post-injection. This in vitro study results show that the viability of RPE cell suspension injection via 41 gauge cannula is comparable to that of 29 gauge cannula, and it maintained an average viability index of more than 90% post-injection. And we all are aware that day-to-day in subretinal procedures, we are more comfortable with more narrower needle. So this can be extrapolated clinically, that the routinely used subretinal 41 gauge cannula can be safer for RPE cell suspension delivery. Concentrated RPE cell suspensions offered better cell survival as compared to diluted cell suspension. And the cells did not undergo significant extended stress post-injection. Thank you.
Nice presentation. So how it help us in understanding the retinal diseases? Just add to.
I think, thanks for the question, ma'am. I think it is, with respect to the therapy, it will help than understanding the disease. In the therapy, as we are aware that the stem cell therapy is the one which is for retinal dystrophy as well as ARMD, the stem cell therapy. So the technique of delivery, the subretinal technique of delivery, the needle is always debated, the narrower and the wider gauge needle. So for the basic scientist part, it is that the more wider the range, the cell survival is good, because we are not providing any stress to the cells. But for us, for retina surgeons, the more narrower the needle, more safer to inject and also to maneuver subretinally. So this will help. This is just a giving idea that even the narrower needle, we are able to have a good cellular survival
viability
when compared to the wider one. But this has to be done with the iPSCs, because this was just a lab experiment. If we do it in vivo, then it will give better results.
Okay, thank you.
Thank you.
What are the diseases you are targeting by this method?
Yeah.
Clinically.
ARFD would be good. After that, it should be Stargardt. Okay. Then with retinitis pigmentosa, because there are guidelines for cell therapy. So all the diseases where RP cell function is affected, we can use them.
Not livers.
Liver will have
Stargardts.
Stargardts. I just highlighted that it should be used. Liver will have very short window period. I'm not sure whether it will work there or not. Thank you.
Thank you. The diagnosis of subclinical neovascular AMD with OCT angiography. Dr. Rama Kumar from Madhya Pradesh Ophthalmological Society, State Ophthalmology.
Good afternoon, session officials and my colleagues. I'm going to present on diagnosis and follow-up of subclinical neovascular age-related macular degeneration with OCT angiography. There is no financial interest. So the Conan study group has defined the subclinical neovascular AMD. Though AMD is defined as a condition, patients beyond 50 years of age in which structure and function of the macula deteriorates. In that, non-exudative MNV, that is macular neovascularization, it has been recognized, and it could be identified more commonly with advances in imaging technology. But previously it was named as quiescent CNVM. So the Conan study group, which has recently published AMD nomenclature, they didn't agree with that word quiescent. So all those cases of neovascularization, sub-RPE neovascularization without signs of activity, clinical activity, like exudation, that is fluid, either retinal or subretinal, and subretinal hyperrefractive material or hemorrhage. Any of these things, if they are not there, then it is called as subclinical neovascular AMD. So there are certain, like after the advent of imaging modalities like OCT angiography, ICG angiography, and recent other things, there are certain publications regarding this, and in this publication they found that by 12 months the risk of exudation was greater for eyes with documented subclinical MNV compared with eyes without detectable MNV. So they could see progression in certain cases with subclinical MNV at 12 months age, at 12 months follow-up in this study. So the other study found that out of 34 fellow eyes of frank AMD cases, they could find subclinical MNV in 5 cases, and in that only one patient developed clinical neovascularization. They tried to look at the subclinical characteristics of the subclinical neovascularization, and they tried to see if there are any specific characteristics which can predict the conversion to clinical neovascularization in the follow-up period, but they could not find any such this thing, and they also mentioned that treatment is not required for these subclinical CNVMs. So my abstract regarding my study is a observational prospective study. I just followed up the patients where clinically, when I examined and found that there is a subclinical CNVM, I followed them up at least for a period of 6 months, and then I'm trying to present my results. So I'm directly presenting the cases here. So there was a 54-year-old female who came for a routine checkup. BCVA was 6, and 6. There was an RPED near the fovea in the right eye, which prompted me for OCT and OCT angiography. If you can see here, there is an RPED in the right eye, and when I did the OCT angiography, you could see the flow signal in the B scan, and also a subretinal sub-RPE neovascularization on the outer retinal slab. So this patient was followed up for almost more than a year, and you can see this I kept as a reference, that other eye outer retinal slab for a reference. So though there is little change in the shape of the vasculature has little grown, there is no clinical evidence of activity in this case. And there is a second patient who was a 60-year-old male. His 65-year-old brother was treated by me only for peripapillary CNVM, and the 85-year-old mother was also treated for neovascular AMD, frank neovascular AMD, and BCVA 6, and 6, and there was a subfoveal RPED, and which prompted me for OCT angiography. You can see the flow signal in the B scan, and also a neovascularization in the outer retinal slab. This also was followed up for almost 6 months, and then there was no growth in the neovascularization. And third case was a 74-year-old male who was diagnosed as frank AMD, wet AMD in the right eye, and when the other eye octa was done, there was a subclinical neovascular AMD. So this was also followed up, and this patient, you can see there is a frank wet ARMD in the right eye, but there is a subfoveal RPED which didn't show, which did show that CNVM in the outer retinal slab, and also a flow signal in the B scan. So this is the patient who has longest follow-up in my this is the right eye showing the neovascularization. So this is the patient having the longest follow-up. You can see August 2021 to April 2023, more than 1.5 years. If you can see towards the disc, there is a growth of the CNVM, but there is no clinical activity of the CNVM. So I'll show you this. So if you can, I tried to focus on that area where there was a growth towards the disc, and here also the flow signal was there in the B scan, but there is no clinical activity on OCT. So this is the fourth patient. Left eye 6/9 vision was there, and when I did the OCT angiography, there is a atrophic area also in the area of the RPED. So the vision was little less, but though there was no clinical activity, no exudation, no subretinal hyperrefractive material, So this patient also showed neovascularization in the outer retinal slab, and during follow-up, this is also almost more than almost an year follow-up, and there is no change in the neovascularization and no clinical activity. And this fifth and sixth patients, there was MNV, but I could not get the follow-up octa, though I could see them at the end of 6 months and 8 month follow-up. There was no drop in vision. Both of them were maintaining 6/6 vision. So this was the outer retinal slab, this thing. So for a reference, I have made another patient who had a frank AMD in the other eye, and this eye showing a subfoveal RPED, but there is no neovascularization. So I conclude by saying that there is no need to hurry to treat subclinical AMD till the time we get more prospective studies with sufficient numbers, with widespread use of octa and other advanced imaging investigation modalities. Thank you.
Just did you measure the thickness of the choroid?
Pardon?
Because did you measure the thickness?
I
of
didn't
the choroid?
classify into the pachychoroid and the AMD different things. I just looked at the neovascularization.
Because most of them had a thicker
Pachychoroid.
choroid compared to.
Yeah. There is another paper which has published the neovascularization associated with the pachychoroid and the neovascularization associated with AMD. But like in these cases, one patient had a family history of AMD and the other patient had other eye AMD. So difficult to say whether to name it as a pachychoroid related neovascularization or AMD itself. All are fitting into that more than 60 years of age.
I have a question.
Yes.
You have shown the patient is 6/6 and he's having subclinical neovascularization.
Yeah.
And clinically there are no signs. But if the patient is having symptoms like metamorphopsia, then would you inject or?
No, without a
If the patient is
evidence of
symptomatic.
without an evidence of clinical, because as I mentioned, the diagnosis of activity is given by either a presence of fluid, either retinal or subretinal, or hemorrhage, or subretinal hyperreflective material beyond, like in front of the RPE. So if anything of these things are not there, and if just the because we do see serous RPDs giving metamorphopsia also, and we are not treating them. Just like that, we are not treating them. As on today, the recommendation is that not to treat, because in all the diseases we are going for early detection, like glaucoma, also pre-glaucoma, all these things. So they go for some kind of precautions or preventive treatments in those cases. But here, because there is cost involved and there is a lot of issues with the patient coming for the treatments, there is no need for hurrying up for the treatment in these cases. That is what I wanted to put forth by showing these cases.
Now, what are the specific things where you include them as subclinical neovascularizations? What are the criteria where you have
that's what I mentioned. It may be a routine clinical examination which is showing a RPED, or wherever you are doing a OCT. If you are finding an RPED, do an octa and see if there is a neovascularization. But no clinical activity. Clinical activity defined by fluid, either retinal or subretinal or subretinal hyperreflective material. We call it as SHREM, and hemorrhage. If these three are not there, then it is subclinical.
I think. Have you done ICG in any of these patients?
No, I don't have an access for ICG.
And what
previously, when they started giving a diagnosis of subclinical AMD, they started with ICGA. But nowadays, all the recent papers which are published are based on OCT angiography.
And what would be the follow-up protocol do you follow for these patients whom we are not treating?
I'm taking it as 6 monthly follow-up.
6 months.
I'm advising the patients who had pathology in the other eye, they are coming anyway for the regular follow-ups. Like one patient has been getting treatment for wet ARMD in the other eye, so he's coming for a frequent follow-ups. But otherwise, without anything in the other eye and only for this eye, if I have to call, tentatively there is no recommendation for this as such. Tentatively, I have taken it as 6 months.
As it was rightly mentioned, like it could be a part of the pachychoroid spectrum itself. Like if you follow it up and if the choroid is thickened, and if you have an ICG on that, if you see a hotspot in the later phases, probably treating, is vision the only criteria we are looking at?
Pardon?
Is vision the only criteria we are looking at? Because vision has never dropped.
Yeah, vision has never dropped. I'm looking at the activity, clinical activity on the OCT also, no? All the B scans I have tried.
Sometimes the OCT won't show anything.
That's what I'm saying. See, I showed one of the cases, there is a growth in the neovascular membrane,
Right.
but still there was no clinical activity. So my proposition is that till the time you don't see the clinical activity, because not to increase the treatment burden on the patient, cost-wise also, and for the treatment purpose also, not to increase the treatment burden, I propose to say that whatever that has been worldwide has been proposed, not to treat subclinical cases. Till the time they become frank clinical cases.
Thank you. I think we have exceeded time.
Yeah.
Did you see the choroidal vasculature in both the eyes of the patient who had a clinical membrane and which one didn't have the?
No, I didn't get into that
because
detailing.
you can very well see it on the OCTA
Yes.
and probably will be able to diagnose it better.
Yes.
That is one.
Thank you.
Thank you.
Next, the chairs can come for the next session.